Good afternoon, everyone. Welcome to our second week in our current series on reducing readmission rates. This week, we're going to be going over our care transition reports and how they can be beneficial to you from the QIO. We have Dr. Lynn McNichol here with us today, who is going to be going over today's topic. But before we get into that, we do have a couple of housekeeping items we'd like to get through first. So if you're not familiar with the IPRO QIN-QIO, IPRO holds the federally funded Medicare QIO contract for the regions shown here. IPRO specifically helps support New York, New Jersey, and Ohio. Health-centric advisors help support Connecticut, Maine, Massachusetts, New Hampshire, Rhode Island, and Vermont. And Clarent helps support Maryland, Delaware, and the District of Columbia. Together, we are three organizations under the IPRO QIN-QIO banner. So if anyone asks if you're working with IPRO or health-centric advisors or Clarent, you say yes. At this point, I'd like to pass it to Mary Ellen just to give us a brief COVID-19 update. Mary Ellen?
Hi, Josh. Thanks. And hi, everybody. So weekly hospitalizations have increased as of the last reporting week. Not a surprise. We're in the throes of the respiratory virus season. An increase of 8.6%. Deaths have increased as well. The good news is the latest variants have remained consistent, so that is good news for the effectiveness of the updated COVID vaccine. Next slide. So I just want to keep this on folks' radar as COVID-19 cases have continued to rise. We're seeing an increase in influenza. Again, it's not a surprise during this active respiratory virus season. But I just want to point out that the biggest climb is in the age group of 65 plus. So really important to encourage people. It's not too late to get a influenza vaccine. If you look at the next slide, it just shows where we're at as far as vaccine uptake with influenza, far below the targeted goal of 70%. But we seem to be on track for about the same compliance rate with influenza coverage, which hovers around 46%. So again, really encourage influenza vaccine uptake. It's not too late. The CDC is going to be putting out a vaccine campaign messaging next week during National Influenza Awareness Week that not too late to get a flu shot as we go into the winter and spring months. And that's it. Thanks, Josh.
Thanks so much, Mary Ellen. At this point, I'd like to pass it over to Dr. Lynn McNichol, who is going to get us started with today's topic. Lynn, over to you.
Thank you, Joshua, and thank you, Mary Ellen. I actually would like to add that people should also get the RSV vaccine, which I've been promoting in my practice. And so far, people have had pretty decent responses, not too many allergic or immune responses, side effects to the vaccine. So hopefully people will start increasing their uptake of that. So today I've been tasked with talking to you about this great transitions report that the nursing homes can obtain from their QIN-QIO. And this is called the Care Transitions Report. And what we're going to do today, next slide, please, is talk a bit about why this report can be relevant to you, analyze some of the data in terms of examples, and I have three different types of examples today. We're talking about, I have reports showing the overall region of the QIN-QIO region, all the data from the 13 regions. And then I have an example from one nursing home. And then we have a couple of examples of nursing homes that might be having some struggles. So we also want to understand what are the other data sources that you can use to identify some potential areas for improvement. I used the model of that I'm stealing from Margie McLaughlin of what, now what, so what, and now what. Those are the three sort of strategies that you need to think about. So looking at what does the data tell us? So what? Why is it important? And now what? What are we going to do with it? And I think that that's a very simple way for me to think about how I look at data reports and how I can translate that into actionable improvements in our care for our patients. So just wanted to touch upon the fact that, you know, we're all struggling to figure out what's going on with and who the person is that is coming to us when they get admitted to our facilities. And it's really, really hard for us to see the full picture, right? It takes a lot of effort. The information that we get can be piecemeal, it can be inaccurate. And everybody sort of has a different understanding of what's going on with the resident. And us in the nursing home, you know, if we're at the tail end of things, we're not getting a full picture of this elephant. And really, we need to be figuring out everything that's happening to them, what has happened in the past, what might happen in the future, and how we can get a full picture. And hopefully you're able to get access to the medical records in the hospitals so that you can at least investigate and get a better picture of what's happening. Next slide. And the important thing also to consider is that there are lots of pressures going on for the hospital, for the ED, for the nursing homes, in primary care, and the patient is sort of being squeezed in the middle of all of this, right? So the hospitals have pressure for accepting people from whether it's from home or from the ED, accepting people from nursing facilities that can't manage situations that are happening in the nursing home, and transfers from other hospitals. You know, if you're a large tertiary care hospital, you're going to be accepting high-risk patients from your local community hospitals. There's also pressure for getting people into the nursing home directly from the hospital or for direct admissions. Sometimes we feel like we're pressured to take people that might not be medically stable. And we have to feel comfortable saying no. And then there are pressures to get people out of the hospital. The nursing homes want to reduce their length of stay. They want to open beds because the ED is full, the ED is closed, they can no longer close the ED, all those things. It makes pressure to get people out and to our facilities especially. And then the facilities also have pressure to get people out, especially in terms of rehab, you know, in terms of reducing our rehab length of stay, while at the same time making sure that we're not increasing the risk of readmission after our discharge. Because remember, the 30-day counts, whether they're in the facility or not in the facility. Next slide. Next slide, please. Josh. Josh, what can you say? Thank you.
Sorry,
And so, no problem. So the last point I'd like to make before we get into the report is that it's really difficult for us when we admit people to our facilities to get the full clinical picture as to what's important for us, right? Do we have an accurate problem list? Do we understand the specialty care that they've obtained and also that they will need in the future? Do we know if there are labs that are pending, or even the labs that were done? What are some of the important labs that we need to know about? Pathology reports, abnormal thyroid tests, things like that. Do we understand the studies that were obtained and how to interpret them and what they mean for the person? And then, you know, one of my pet peeves is accurate medication lists, knowing what they were on and what was stopped. And sometimes it's really hard to figure out because they say, stop this medication, but the patient or resident had not been on it for 3 months, and yet they've been told to stop it. What are new medications? Why are they important? Why were they started? How long they need to be continued? And then an overall actual complete medication list. We were talking yesterday about an example of an admission that I received where there were 3 insulin instructions, one to give 42 units of Lantus, then it stated, but the patient only takes 16 at home. And then the other list was check with your doctor if you should be taking 28 units of Lantus. And it was very confusing. And I provided that feedback back to the facility, the hospital, to let them know that this is unacceptable. Next slide, please. Thank you. So back to the report. So the care transitions report includes data for your facility obtained through Medicare Fee-for-Service, and it's both for skilled and long-term care residents that are admitted to your facility. It is not risk adjusted. Therefore, as you know, there are facilities that take on much more higher risk residents for admissions, and therefore are at higher risk for readmissions. And so you have to interpret the data in the context of your facility. It's good to compare to the state, but it's, you know, you have to understand your population of residents and whether you're mission driven and you take people that other facilities would never accept, or the other way around. The information that's provided includes all of the things that's listed here: demographics, 30-day, all-cause 30-day readmissions, the number of days to readmission, and it breaks it down for you, and then the top 10 reasons for admission to the index admission to the hospital, the reason they went into the hospital in the first place, and then the top 10 reasons for getting readmitted to the hospital, which is important for you to look at in your facility. And then ED visits, and same things, the number of ED visits by quarter, and then the top 10 diagnoses related to that, and the observation stays within 30 days, and the top 10 diagnoses. Those are 3 different patient populations, right? The people who go to the ED and come back is a much different issue than the people who go and then stay for a little bit on observation stays versus the people who go to the ED and end up getting readmitted for, you know, a full readmission. Next slide, please. So this is the example for demographic data for the entire QIN-QIO. So as you can see, there's a fair amount of people, 280,000 nursing home admissions in our region for the year. July 22 to June 23. And then, so it's a rolling 4 quarters. And then you have had in the entire region 57,000 readmissions for a rate of 20.4%. Now that's, you know, that is what it is. And then it gives you some demographics for gender, age, race, and disability when they were enrolled in Medicare. So presumably most of these, when they enrolled at 65, did they have a disability or not? And then that gives you some identity, some information about the patient population. As you can see, the men are more likely to get readmitted, 22% or 23% versus 19% almost. Younger people in this patient population are more likely to be admitted, and then it gets less and less as they get older. Looking at this entire region it's great because you can look at the distribution of race a little bit better when you're looking at a smaller facility. It just gets very difficult to interpret race because it tends to be predominantly one or the other, you know, and in the facility we'll show in a minute, it's predominantly white. But here you can see that there's some differences. You know, Native Americans actually have a lower rate, and then it's Caucasians or white. And then the rest have a slightly higher rate, you know, 2 to 3% higher, which is interesting. And is that disability, sociodemographic issues, inequality? And as expected in this slide, 23% of beneficiaries with disability are readmitted versus 19.6%, which is what you would expect, right? Next slide. So this is an example of one facility. So you have the admissions information for that facility, and then in the green column is the state. And so you can compare this particular facility there. They had 80 admissions during this year and 12 readmissions. So they have a rate of 15%, which is actually much better than the state, which is 19.4%. So it's really interesting what they're showing. Next slide. Yeah, so I was just highlighting that it's a full year. Next slide. So when you look at this data, again, it's important to think men are more likely to get readmitted. Why is that? Are men more sick and frail when they come to a nursing facility? Do they have diseases that increase their risk of readmission, such as systolic heart failure, which is a possibility? And then age, in the population, it's lower in people over age 85. So why is that? You would potentially expect a higher rate of readmission. They're frailer, they have more comorbidities, but is it because they have more advanced directives, or they have more likely to have do not hospitalize? They're more likely to be long-term care residents? I don't know. And then race, as we mentioned, it's much easier to analyze on a larger scale. When you come to a smaller scale, it's just in the facility, it's harder to differentiate. And then, as expected in the larger group, the rates among people with disability was higher. But in our facility that I mentioned, the rates were lower, and I can't figure that out. I haven't figured out why. Next slide, please. Thank you. So this is the first also important slide for figuring out your outcomes. So this is all-cause 30-day readmissions, and this is for the facility that the example facility. And you can see it shows your facility rates, your state, and the actual numbers by quarter. And this shows significant variability, right? The state is the dotted green line, which is pretty stable and steady. But this particular facility goes from 22% to 0% in from quarter to quarter. And so you have to ask yourself, next slide, please, what's going on with this? What is the reason for this variability? Is it staffing? Is it vacations? Is it new nurses that are being onboarded, or a sudden drop in the nursing aides? Is it consistent with COVID outbreak? So you need to figure out with your facility what's happening. Why is this huge variability? And facilities should, as you know, be reviewing their hospital readmission cases and determining root cause analyses and preventable causes. But perhaps you would want to target those months or quarters where you have the high rates and figure out what's happening within the system and how it correlates. Next slide. So this is another example. So then you'd have to figure out what's going on. What are we going to do with this? So this isn't quite panic stage. As you can see, their rates in this facility are very low, 6% for over a year. And then all of a sudden it starts to creep up to 15%. What do? You'd certainly need to convene a committee and do an in-depth analysis, maybe going deeper than what you would normally do. You might want to work with your main facility hospital that you're getting readmissions from, or admissions, and identify, are there any transitions opportunities? Certainly I would encourage people to provide immediate and ongoing feedback on errors, near misses, and miscommunications, just as the example of the insulin orders, fiasco that I mentioned earlier. I let that facility know that this happened and what were the details, and they're investigating. And I said, this is not acceptable. We shouldn't be getting this, or trying to figure out what's the right thing for this person. There are probably errors on our side in terms of taking on patients and even sending them over to the hospital in terms of transitions of care. So both the hospital and the facilities need to work together. And then, of course, you have a huge resource in the QIN-QIO. They can help you figure out what exactly is going on. So please outreach to them. Next slide. This is another example. So look at this. I mean, they're below 5% for a year, and then all of a sudden they hit 25%. That's a 5 times increase in readmission rate. So I think maybe this is panic mode. However, you have to consider that the number of admissions was lower than the average for the previous year. And they really just went from a high of 3 to 8. So that's 5 additional readmissions. So it's not like they went from 3 to 15, but it's still a huge increase. And I think you definitely would need to call the QIN-QIO at this stage to figure out how to attack this and do something now before things continue or get any worse. Next slide. So the next important piece of information is the days to readmission. And this is the entire region for the QIN-QIO. And you can see that there's a bimodal distribution, from 3 to 14 and then 21 to 30 days. But it's pretty consistent, after the first couple of days. And what you would expect is that the rates are lower for 1 to 2 days, because if you've got high rates at that stage, then there's something going on with the transitions of care that you need to deal with, whether it's from the nursing home side or the hospital side. Next slide. So this is the example nursing home that we mentioned, and what's interesting for this nursing facility is their data are in blue and the state is in green. And you can see that the state average kind of increases gradually with the days in increasing days, whereas it's much lower for this particular facility, up to 14 days. And then you see the rates start to go up. And almost 2/3 of their readmissions are after 15 days. Next slide, please. So it's a really different pattern compared to the state or even the region that we looked at. So why is that? What's going on? Is there a honeymoon period for this particular facility where they're able to manage the resident initially during their have low readmissions, and then they stop paying attention as much, and then they're after a while they are not doing as many labs or following up, and that's when things start to deteriorate. So it's really important for this facility to look at readmissions after 21 days, and then also you'd have to think, are there readmissions that are occurring after discharge from the facility? So are these happening within the facility, or are these happening once they go home or to the assisted living facility and then get readmitted? So that's really important to pay attention. Next slide. This is an example of another facility that, as you can see, the blue for days 1 to 7 are much higher. This is, as I mentioned earlier, an issue with transitions of care, likely, whether it's on the hospital or the nursing home side or both. They need to figure this out. Why are the readmissions happening so early after the discharge from the hospital? And then, you'd have to think, are the medical providers coming in to see the resident in time, or are they waiting 5-6 days and by then things have deteriorated? Are there issues with medication, that there's misinformation or miscommunication with medications? Are residents being discharged too early from the hospital? Are these Friday or weekend admissions? And therefore things don't get taken care of or things deteriorate over the weekend. You need to figure that out pretty quickly. Next slide. So the next are index and readmission diagnoses. So this is for the particular facility, that the example facility. So they have 4 of their readmissions for that year that are related to septicemia. So that's a pretty high number. Next slide. And the reasons for being readmitted, their top number is complications from surgery or medical care injury. So, and then coagulation issues. It's really hard to tell because the numbers are so low. Next slide. So sepsis is really important for an index admission. So you might want to target those people and, you know, really pay attention to those residents that come in with the diagnosis of sepsis. And some of the reasons for readmission are clearly preventable, or could be preventable, such as a fracture, a coagulation issue, or a complication with the orthopedic device. But other diagnoses don't make sense, like Parkinson's. Like, why would somebody get readmitted for Parkinson's? It doesn't make any sense. But that's primarily because we're looking at you know, data submitted to Medicare, and it's not always, doesn't always make sense. Next slide. This is the overall data for the region, and this is more important for us to identify sort of interpretable causes across our entire region. So sepsis and heart failure are some of the most important reasons. And third is fracture of the femur, so hip fractures, which are also important. Next slide. And then reasons for getting readmitted to the hospital, again, sepsis, heart failure. So really important to consider those. And then as you can see, the next three are acute renal failure, Foley catheter issues, and UTIs. So pay attention to sepsis, pay attention to heart failure, and pay attention to urinary issues or renal. Next slide. Next slide, please. Can we have the next slide, please? Joshua? Josh, could I have the next slide, please? Okay, so let me go on with my slides. I don't know what happened there. So what I was going to show is, it's coming back. Okay, so there we can move on to the next slide, please. So this is an example from the nursing home that we were talking about of ED visits. So as you can see, again, there's tremendous amount of variability because the numbers are so low for this facility. But you have, you know, one quarter where you have 3 ED visits, and then, you know, many that you don't. Next slide. And these are the particular reasons in this facility. So chest pain, fluid electrolytes, ruling out something, genitourinary symptoms, which are probably UTI, and respiratory signs and symptoms. So again, some of these things might or might not be preventable, you know, if we identified these issues sooner, maybe. Next slide. And this is the region. So it's about 9%, and it's pretty steady across the last 2 years of data. Next slide. And these are in general for the entire region. So superficial injury, so say something that needs stitches, UTIs, respiratory, and pain. Next slide. So there are a few ED visits for this facility, but residents tend to require hospital stay. So for this particular facility, and maybe you would say that they are appropriate for transfer to the emergency room. So I would say this particular facility is doing a pretty good job. Next slide. And then total observation stay, I didn't actually show the facility because they had none for the last several quarters, but this is about 2%, which is pretty steady again for the entire region. Next slide. And again, it's chest pain. Sometimes you just have to be admitted for a chest pain rule out. And UTI, unfortunately, should not be one of those admissions. Next slide. So I wanted to just briefly mention a quality review process that was published a few years ago, which I really like. It was a study looking at a Boston Medical Center and 2 SNFs, and they looked at a process of analyzing readmissions together. There was some discrepancy in whether things were preventable or not between the hospital and the SNF, but overall they found that end-of-life planning and medical complexity were important factors in readmissions. And they did develop some cross-continuum QI projects together to figure out how to reduce readmissions. So I just want to put that idea into your heads that it is a feasible thing to do with your facilities, and I would encourage it. Next slide. So you can obtain your own specific reports. Just let us know if you'd like to, and we'll send that to you. I would think of it from the 3-step process of what, so what, and now what. And hopefully you'll end up with steps that will help reduce readmissions. And then use the QIN-QIO as a resource and discuss your results, figure out how to move forward. And you'll get many more examples or suggestions, ideas, strategies in the next few weeks as we delve into this further. Next slide. And here are some resources, and that's it. And I'm a minute over, I apologize.
No worry, Lynn. Thank you so much. Does anyone have any questions for Dr. Lynn McNichol while we're on the call?
No, but thank you. That was wonderful.
Thank you. I really encourage people to get the reports, and then you'll be able to get your individual data. If you wanted a quarter's worth of patients, you can delve into that further in the report. So
Yeah, if you're interested in getting your own facility level report for both for either your care transition reports, or even we also have standard analytic reports which go over your quality measures. So if you're interested in either one of those, please feel free to reach out to us. Our contact information is here. More than happy to connect with you and provide you those reports, set up time with you to review them, and give you some feedback in areas for opportunity to work on.
and Joshua, they'll be able to get the slides, right?
Yep, I'll be able to send out the slides once I get the final version from communications. I'm not seeing any other questions aside from that, so should be all set for today. We do have a live recording of the session again tomorrow at 3:30. So if you know anyone who would benefit, please encourage them to attend. We also have our IP3 session this Thursday at 11 a.m. Actually, hold on. We have a new day, which is our all-day nursing home conference. And I can send out a registration link to that session for anyone who's interested. It's from 9 to 3. And the sessions are back-to-back. Anyone who's interested, you can just come in for any sessions you might be interested in. You can drop off. You can come and go all day, let it play in the background, whatever works for you. But I can send the registration invite for that session after this call. So Cindy asked a question, do we need to give you an email? So Cindy, everyone who's registered for today's session will get a follow-up email with the slides afterwards. So if you're registered, you should be all set. All right, well, that'll be it. Thanks so much, everyone. Have a great day.
Bye.